Thank you so much for having me here. I'm really excited and honored to be here. And thanks for that introduction. This is an especially big honor for me. Just personally, my family, my mother's side of the family comes from Ukraine. And so very big honor for me to be able to meet with you all today. As described, I'm going to use my time to talk about some recent advances in our ability to understand suicidal behavior and predict it and prevent it in particular. And I'm going to talk in particular about the use of newer technologies and about how some of these new technologies have really led to, I think, pretty significant advances in just the past 5 or 10 years. So to start out, as was alluded to a few moments ago, suicide is a very complex clinical problem. It's one that we as humans have been thinking about for literally thousands of years. Since the beginning of recorded history, philosophers have written about the question of suicide. Should we live? Should we die? Unfortunately, without much progress, without much improvement. In the United States, suicide continues to be the 10th leading cause of death. And it's around there, 10th, 15th around the world. Whereas the mortality rate for most leading causes of death in the US have decreased over the past, say, 100 years. For instance, mortality rate due to cancers, tuberculosis, pneumonia, HIV, AIDS, accidents have all dropped over the past 100 years. The suicide rate now is virtually identical to what it was 100 years ago. We haven't seen the same progress. We have identified some risk factors. We've identified some promising interventions, but I would argue that our progress has been slow and in many ways unacceptably stagnant. The earlier scholar, W. Edwards Deming, has given us one of my favorite quotes about science: "In God we trust, all others must bring data." And so I want to share some data on this question of how much progress have we really made in advancing the prediction of suicidal behavior. So these data that I'm going to show are from a meta-analysis or study of studies looking at risk factors for the prediction of suicide. And I'm going to show odds ratios. Odds ratio of 1 means that the predictor is not associated with an increase in the odds or roughly risk of suicide attempt or death. The higher the number, the stronger the predictor. And one thing we wondered is, are we getting better? Have we gotten better over the past 50 years in identifying accurate risk factors for suicide? And it turns out we haven't. We're not identifying stronger and stronger risk factors. The reason is, if we look at what kind of risk factors we've examined over the past 50 years of research on suicide, and I'm showing here the top 5 types of risk factors examined in each of the past decades, you see that about 75% of the time or more, we're looking at the same 5 risk factors: sociodemographics, ICD or DSM, internalizing, externalizing symptoms, prior self-injurious thoughts and behaviors, and negative life events. And we typically have done this using surveys or interviews. So perhaps it shouldn't be then surprising that if we're looking at the same predictors and we're using the same methods, we shouldn't be surprised that we're getting the same result. So I would argue that what we need is new approaches to prediction and prevention of suicide. And we shouldn't just use new technologies because they're available, but instead we should look to try and fill gaps in our understanding. And I'm going to talk about 2 in the time that I have in particular. One is the need to develop methods for better combining information about known risk factors. And the other is the development of better data on imminent risk. And I'll spend just under 10 minutes talking about each of those. So first, in terms of combining information about risk factors, we have identified risk factors for suicide. Looking back to the meta-analysis I mentioned, I'm showing here the top risk factors for suicide death from the past 50 years of research. You'll see that treatment history is the strongest predictor with an odds ratio of around 3, probably not because our treatments are killing people, but because people who are suicidal get themselves into treatment. After that, we see all of our strongest risk factors have odds ratios between 1 and 1.5. which means there's no one risk factor that puts people at high risk for suicide. Suicide results from the combination of a number of different risk factors. And this is true in the general population. This is also true regarding war, which I know is a topic of discussion for this group for the obvious reason. We know from over a decade of research on suicide that a lot of the same risk factors come into play among those participating in war, soldiers, veterans, and in civilians who are impacted by war. There's some really nice work led by Eli Karam of Lebanon. He published a paper in 2012 in Psych Medicine as part of the World Mental Health Survey Network led by Ron Kessler at Harvard, and found that post-war, we did see increases in suicidal thoughts and behaviors, and those were explained by increases in mental disorders like depression, impulse control disorders, substance use disorders, and so on. Bob Bersano, who was mentioned earlier, who's here, has done really wonderful work in the U.S. Army STARS research project showing that military units where there are more suicides, we see increased risk of later suicide attempts, especially smaller units, perhaps where people are more impacted. Similarly, from Army STARS, we've seen risk factors that we know from the general population, like traumatic brain injury, PTSD. When those symptoms are present pre-experience of war, those are risk factors for later suicide attempts after someone experiences war. So a lot of the same risk factors that we see in the general population, the general literature, seem to be relevant for suicide related to war and combat, and we just see elevations of them around this time and in groups who are affected. Most of the studies that have been done, though, almost 100%, 99% of studies have looked at one risk factor at a time. So they look at the effects of depression or anxiety or alcohol use disorder and so on. We haven't been good at providing information about combining known risk factors. So we need better methods of doing that. And so what I want to show are results from one study that was also done as part of the Army STARS initiative. And this is work led by our colleague Ron Kessler. And the attempt here was to try and improve the prediction of which patients die by suicide in the year following a psychiatric hospitalization, which we know from decades of work is a really high-risk period. When someone comes into an inpatient stay with a psychiatric diagnosis, their risk of suicide is extremely high right upon discharge and remains high for the weeks and months afterwards. And we're not really good at identifying which patients leaving the hospital are going to die by suicide. So what was done in this study was try and use machine learning methods applied to medical records and administrative data that were all kept electronically to create risk scores for each hospitalization to see, can we identify which patient at a given hospitalization is going to die by suicide in the next year. And so I'm hearing some background noise, but I don't know how to control it. So I will keep presenting. Data here were from over 50,000 hospitalizations over a 6-year period among U.S. Army soldiers. And so to be clear, what was done was a risk score, a predicted probability of suicide death was created for each hospitalization, and soldiers were followed for 1 year after discharge. And what I'm going to show is a figure with 20 different bins. Each bin is a 5 percentile band, a ventile. And on the vertical axis, I'm going to show how many suicides occurred, what percentage of suicides occurred in each bin. And if the model's accurate, what we want to see is the suicide deaths piling up on the left side of the screen. And that is, in fact, what we saw. And in fact, people in the first ventile, that first ventile contained over half of all suicides. So whereas the suicide rate in the U.S. Army at the time was 18 per 100,000, in that top 5% bin, it was 3,800 per 100,000. So a lot of the risk is concentrated in this top bin. And people often think about looking for suicidal patients, identifying suicidal patients as finding a needle in a haystack. And so what this approach did was take a hayfield, separate it into 20 different stacks, and we found that more than half of the needles were in that first stack. So a really high concentration of risk. On the flip side, most of the people in that bin did not die by suicide. So you'll note 3,800 per 100,000 did. That's about, call it 4,000 per 100,000, or about 4 out of 100. So 96 out of 100 people in that group did not die by suicide, which has led some to question the clinical utility of an approach like this. What was interesting in this study, though, beyond what I've shown already, is if we expand the range of outcomes, negative outcomes that we're thinking about, we see that about 46%, also about half of patients in that top bin, if they either died by suicide or died by accident or had a suicide attempt or had a rehospitalization. So half of people in the top bin had what we would consider a negative clinical outcome, which I think highlights that this approach is really tractionable if our goal isn't just to prevent suicide, but to prevent these other negative outcomes as well. So a take home from this is a lot of adverse outcomes in psychiatry seem to hang together. And a prediction model built for suicide, also predicts a lot of other adverse outcomes. And to reiterate, this was done with data lying dormant in patients' medical and administrative records. Not a single patient was talked to in this process. This is all done using data that were available digitally. This was done in the Army in a similar study done in a civilian, the Harvard Healthcare Network, using a slightly different machine learning approach. We had very similar findings. We found that using patients' electronic health records and machine learning applied to them, we could identify patients at risk for suicide attempt and suicide death several years before they had their suicidal behavior. And we recently replicated this in 5 different civilian healthcare settings around the US. So we basically exported the machine learning approach, gave it to 5 different healthcare systems. They ran a model locally and found very similar predictive accuracy, which suggests this isn't just going to work in the US Army. It's not just going to work in the Harvard healthcare system. This approach seems to work. It's worked so far in each system in which we've tested it. Last point on this arm of research, we also wondered, can we improve prediction beyond just looking at digital data and healthcare records by getting additional sources of information? And in the study I'm going to describe next, we got data from 2,000 patients presenting to a psychiatric emergency department, also a high-risk group, collected data from 3 different sources, and followed them for a 1-month period of time post-hospital. We used machine learning applied to their electronic health record, as I just mentioned, but we also gave each patient a tablet, an iPad, and asked them about 70 questions that are top risk factors for suicide. And we also asked each clinician who saw the patient what the patient's likelihood of suicide attempt was in the near future. And we looked at the predictive accuracy of each approach and combinations of those approaches. And what we found was that, replicating prior research, we saw that clinicians were not much better than chance at making these predictions. The AUC, or area under the curve, ranges from 0 to 1. 0.5 is basically a coin toss chance. 0.6 is a little bit higher. So clinicians do better than chance, but just a bit. Machine learning on electronic health records did a fair bit better. And when we combined machine learning with patient self-report, that gave us the best prediction. And here we found that of those we determined to be at high risk in our top bin, about 30% of those determined to be at high risk made a suicide attempt in the next month, which we think is certainly clinically actionable. And shortening the 70-item self-report battery to 20 items takes patients only 4 minutes to complete, perform just as well as the full model. And we've now begun deploying this in local hospitals. So we have a 4-minute battery that we can hand to patients in the emergency department to identify which patients coming through are most at risk for suicide attempt in the near future. And we're about to begin a large-scale randomized controlled trial of 4,000 patients to test out if giving this information to clinicians decreases likelihood of suicide attempt in the near future. I want to shift gears to talk about now getting data on imminent risk from patients. So for those of us working as clinicians, we really want to know which patients are going to be at risk for suicide right now. We wondered as a team, well, what time period do existing studies actually cover? And looking back for the last time to that meta-analysis I mentioned, This figure shows how much time passes from when a patient is assessed until a suicidal outcome is observed. And we see that for the research that's been published over the past 50 years, about a quarter of all of that research has made predictions about 10 years or more into the future. On one hand, it's impressive if you can predict what's going to happen in the year 2033. But if I tell you your patient is going to make a suicide attempt in 2033 or beyond, not so helpful in the near term. Similarly, about a quarter of research has made predictions between 5 and 10 years into the future, and about half of research has been 1 month to 60 months. What percentage of studies have looked at the time period that clinicians are really interested in? Let's say the next 4 weeks. It's only 0.1% of all research. So literally 99.9% of all of the studies that have been published over the past 50 years on the prediction of suicide have looked at time periods that simply aren't very useful to clinicians. And so we need better data on the natural unfolding of suicidal thoughts and behaviors. And this is a point that I think is important for psychiatry and psychology more generally, this last one. I think this is what differentiates us from most other areas of science and how they operate. If we think about astronomy or ecology, biology, chemistry, these areas all identify something of importance in nature, and they carefully observe it to understand its properties, and then probe its properties to see how it can be changed. In psychology and psychiatry, we've done something different. We find something interesting in nature, depression, substance use, but then by and large, we bring people out of their environment into our laboratories and expose them to somewhat strange, analogous conditions to what happens in nature. We give them brain scans, we draw blood, we do behavioral experiments. I think that's why we haven't gotten a good understanding of how these behaviors that we're interested in actually occur in nature. We haven't been able to do this because we haven't had the tools to be out in nature with people as they go through their everyday lives, but now we do, because we've all become cyborgs walking around with these digital appendages. And having people carry around smartphones and wear smartwatches allow us to capture moment-by-moment data from people's daily lives and allows us to do what has been called digital phenotyping. And so we can capture fine-grained data on fluctuations in a person's daily life, on suicidal thoughts, on drug urges, on experiences of mania, of depression, and so on. We can use this approach to test theories that we have in psychology and psychiatry using ecologically valid data. We can also collect never before available data to allow us to develop new theories. And this provides opportunities to intervene before suicidal thoughts and behaviors occur, which we've never been able to do before. And so when this work first started 10, 15 years ago, we used technology like this, Palm Pilots and so on, and we monitored people several times a day for a few weeks. Things have changed really rapidly. We no longer need to ask people to monitor their thoughts and behaviors with Palm Pilots and upload data with modems. Most adults, at least in the US, are walking around with smartphones in their everyday life. And we've begun putting monitoring apps on people's phones and pinging them. So we find samples of people who say they're having thoughts of suicide, and we ping them we send them surveys 4 to 6 times a day, initially just for 1 month, to monitor their suicidal thinking, with questions like this: what is your desire to kill yourself, your intention to kill yourself, your ability to resist the urge to kill yourself? And in initial work, we just plotted what suicidal thoughts look like. I think observing the ebb and flow of suicidal thinking for the first time in real life. And so these are data for about 50 different patients. Each box is a different patient. From left to right in each box is a 1-month passage of time. And on the vertical axis is severity of suicidal thinking, just adding up those 3 questions from the prior screen. And what you may notice is a lot of variability within person. There's a lot of ups and downs, and variability across people. Some people have ups and downs, others have just a straight line. And so we wondered, are there any subtypes or profiles embedded in these data? And so what we did was a latent profile analysis, a statistical approach to try and detect different profiles. And what I'm going to show you in the next slide are the same data, just reorganized and color-coded. And so here's what we saw. We saw 5 different profiles of suicidal thinking that differ based on their mean level and their amount of variability. So people shown here in green had low levels of suicidal thinking with low levels of variability, lots of zeros and ones. People in yellow, low mean, high variability, so they were peakier. People in purple, moderate mean, moderate variability. People in red, high mean, low variability, they never came down to 0. And people in blue, high mean, high variability, so they were bouncing around a lot. Which group was most likely to have made a recent suicide attempt? It was the group in red, although none of these patients made a suicide attempt during the study period. We got a separate sample of patients and replicated this approach and had we found the same 5 profiles, suggesting perhaps this is a reliable way to classify people's suicidal thinking. We're now doing a follow-up study where we're following a much larger sample of people over a much larger sample of time to see if we also observe these same 5 subtypes and whether and how people might change over time. I'll describe just a few other smartphone-based studies that we've done to try and get better at prediction. One thing we wondered is, can variability of suicidal thinking while someone's in the hospital improve our ability to predict who's at risk during this post-hospital period? And in this work, led by one of our brilliant PhD students, Shirley Wang, we tested 3 different models. One was a baseline model, similar to the machine learning one I mentioned earlier. We built a model to tell us when someone comes into the hospital, we have whatever data we have for them, and we use that to make a prediction. Everybody also provided multiple times a day data on a smartphone. The second model was what happens when we add in, when we use only smartphone data, the average of people's smartphone data from hospitalization. So the prediction here is the higher your overall level of suicidal thinking, the higher your risk of suicide attempt after the hospital. And the third model was a dynamic one that looked at dynamic features in your suicidal thinking, the extent to which you had big increases in suicidal thinking, for instance, during hospitalization. We followed 83 patients who were reporting 4 to 6 times a day. And what we found across all accuracy metrics is baseline models did okay. The mean smartphone model did better. The dynamic smartphone model consistently was the best. And the strongest predictor there was a measure called probability of acute change in suicidal ideation. And that refers to the occurrence of big increases from one time point to the next. So having these big surges in suicidal thinking seem to be most important for predicting suicide attempt post-hospital. I'll move through this fairly quickly in the interest of time. I see I'm running a little bit short. We wondered about changes in suicidal thinking during the COVID pandemic when it first started unfolding. And we were conducting this work before COVID began. So we were able to see what kind of changes occurred when COVID first hit. And March 2020 was when COVID was declared a national emergency in the US. That's this vertical line here. We saw huge increases in people's daily reports of social isolation, big increases in suicidal thinking. And the more isolated people felt, the bigger their increase in their suicidal thinking. We found this in adults, but not in adolescents, surprisingly. And I can talk about why we think that might be. We think it had to do with kids being more connected digitally with others than adults at the time. We've also been, and I won't share any results on this, using passively collected data to try and better understand risk. GPS data, call and text data, wearable biosensor data, and we're in the process of adding this kind of passive data to our models to try and improve prediction further. In the study that I mentioned earlier, where we're following 600 people over a 6-month period of time. And what we're doing is trying to get really good at identifying who's at risk when, so we can deploy digital interventions to decrease risk. Historically, using what I would call traditional interventions for suicide, we might, if we think someone's at risk for suicide, refer them to crisis services in the United States. we found out from our work that the vast minority of people actually follow up with those recommendations. One approach that's been developed is what's called a barrier reduction intervention, where we try and identify and then remove barriers to a person reaching out for help. In one early study that we did nearly 20 years ago, we did a randomized controlled trial with 76 people. It took about 2 years to complete, and we found that we could decrease barriers and improve people's engagement. However, it took a long time to run 76 participants. Using new technology, we did the same study. Let's find people at risk, identify barriers. But this time we were able to screen 40,000 people, conduct a randomized controlled trial with 1,500 of them, and this took only about 5 weeks to complete. We did this teaming up with a platform called Coco, which is a safety net for social networks. What this platform does is basically find people on social media or in text apps, find those who are at risk, and refer them for care. And so we work with them to have them screen 40,000 users. They found 1,500 at risk. And this is a text app interface. And so you can see, this is a screenshot from Coco. Coco is in gray. It's saying to the user, hey, you're not alone. What country are you in? And we'll give you services for that country. I said, I'm in the USA. They said, okay, please consider calling one of these different crisis lines. Okay? And I said, okay. Here's where the intervention starts. It then says, so be honest, how likely are you to try the resource I just shared? If people say very likely, they're done. If they say not likely, I'm not going to use the resource, they're randomly assigned to either have it be done or to get a little intervention that looks just like this. This is the barrier reduction intervention. It says, thanks for telling me. Why might you not use crisis services? What are the reasons? I just want to chat. I can't use my phone. I don't want the police called, which is a common one. If they click on no police, they'll get a little barrier reduction intervention that just says, most times when you call crisis centers, the police don't show up. This is extremely, extremely rare, like less than 1% rare for many crisis calls. Okay, so that's the intervention. It's a little automated chatbot intervention. We found that people who got this had a 23% increase in the likelihood of calling a crisis service just afterwards. This is brief, fully automated, virtually free, and very scalable. And we've now developed several different digital interventions of this type that can be very easily deployed and self-administered that I won't share in the interest of time. But just one example of what our team and many others are trying to do to use smartphones, social media, technology that people have nearby to find who's at risk and to try and intervene. So some opportunities for advancing here are using electronic health records and other data sources to build prediction models that can tell us who's at risk. We're trying to get better at short-term prediction using mobile devices and mobile interventions. Some challenges I didn't mention, understanding how best to deliver risk scores to clinicians or to patients without causing harm. There's lots of consideration about the ethics of monitoring people and deploying interventions before getting full informed consent about the nature of the intervention and so on. And I'll stop there and want to acknowledge our funding sources for this work and just some of our collaborators and lab members. And I will stop there and say thank you so much for your time. And I look forward to the next presentation and further discussion about this.
Is there in your appreciation, and I learned this actually from Dr. Bob Arsano, there may be specific for the active duty service members who are fighting the war in the trenches and at the hot zones, a critical period when they transition out of services or when they transition back home to spend some R&R with their families or so. Is that a critical window of suicidality, or what do you think about that?
I defer to the brilliant Dr. Orsano for a more accurate answer. In the U.S., we've seen, there's a lot of, I think, expectation that, during deployment, right after deployment, we'd see huge increases in suicide risk. In the Army SARS study, we saw huge increases in suicide during the study period, right after deployment, during deployment, those never deployed. So we're seeing increases in suicide risk across the board. But we certainly see when people transition out of the Army back into civilian life, huge increases in risk of suicide, huge increases in homelessness as well, and increases in homelessness and suicide traveling together. And so our team, I know Bob's team, Ron Kessler's team, have been focused on that transition out of the Army period to try and help service members when they're leaving. And in the US, we have, the military, and then we have a veteran service, and they're not so closely, they're two separate organizations. And so I think it's especially difficult to capture people up as they're making that transition and provide the needed services. But it's something that we're recognizing and working on.
Yeah, thank you. And maybe if Bob, if you want to comment on what Dr. Nock just said, you can use your time if you can.
Matt's flattery, but Matt's comments are 99.99% accurate all the time, and that's true here as well. We're very much focused on the question of transition out of service as a particular time. That's a challenging piece with the Ukraine, of course, where people go home for a time and then come back again, and that there isn't yet a transition out of time. We did find during Army STARS that actually the time of going home was actually also a risk time when we look at people about mid-time during their deployments, which is a time they took R&R back home. We also saw increases in suicide ideation during that time as well. The other part I would highlight that Matt's, just brilliant work. I hope everyone appreciates that Matt is one of the absolute innovators in approaching suicide, and I listen to him whenever I can. There's always something to learn. But his comments, particularly about high variability in suicide ideation being a risk time, that's a very important observation and finding. And it kind of goes against the way I often think about studies of variability, because I think of variability as around heart rate variability. And actually in the picture of heart rate variability in heart disease, heart rate variability is a good thing. It means the trees are moving, they're not stiff. But in this case, we're dealing with this particular cognition, high variability, meaning going from low to high rapidly and back again, is a risk time. And that certainly warrants a lot more thinking and wonder about, both in soldiers and in civilians. So it's a marvelous observation.
Thank you, Bob. And also make us alert for the variability and also that critical window where we need to be extra alert, and because we're dealing with a country that is in war, and that there's a lot of transitioning in and out of service members. Maybe tap in, dear attendees, if you wish, to this discussion. Open up your mic or in the chat. We have a few minutes if you want to ask a question specific on this, or another question on what you just heard, then please, let's allow you to chime in. Yes, go ahead.
Hello, I would like to really thank you for this still vulnerable and very important and actual issue. But from the other side, I understand that if you're a part of a system, strict system like combatant system and military, you always know how to answer some tests to stage in military to come back and be combatant. Maybe the same situation was in States. And so how really numbers show the actual situation, because lots of combatants, when they see advice, they want to be sure that nobody else will know. And if they dare to ask for help, and if they find a person like me or somebody, we just can't use the protocols we know, and we know that it's not really good and even under legislation, but this moral question is to help the real person, to help the real family, or to go under what protocols and other issues says. So what would you suggest to meet ends?
Okay, an excellent question. Yes.
Really, really excellent question, and certainly applicable in the US for our soldiers who are coached to, how to answer questions so that they avoid intervention, so that they don't get taken away from their unit or delayed in seeing their family. And we see it in civilians, of course, as well, who don't want to be hospitalized or want to avoid treatment. We've been working on a few things. One is, using these prediction algorithms that don't rely on patient report, so we can pick up people at high risk who, without asking them whether they're thinking about suicide. Now then we interview them, and they still could decline or deny any suicidal thoughts, and so there's a problem there. But that's one way of finding people at higher statistical risk without having to rely on what they tell us. We've also been developing and using behavioral tests. We have one called the implicit association test that shows words or images related to suicide and asks people to classify them. And based on the speed with which they classify them, we can get a sense of how are they thinking about suicide. And we found, I can put some of this work in the chat, we found that this method, and we have a version that takes 90 seconds, can predict which patients make a suicide attempt with a higher degree of accuracy than self-report measures, than clinicians. There too, though, a patient could be at high risk and still say, no, the test is wrong, I feel fine. So ultimately, we're relying on patient report at the moment, but we're working on ways of trying to get better at identifying which patients, which soldiers, which service members we think are going to be at higher risk and might benefit from additional clinical attention. Yeah. But it's a really, really good and very difficult question.
Вітаю, дуже радий бути присутнім.
Hi, I'm very glad to be here this event, and thank you so much for this great, detailed and very structured presentation. My question is on possible or actual quantity of people who abuse substances as the share in the general quantity of those with the suicidal ideations. I hope you understand my question. So, what is the share of people who abuse substances in the total sample?
So, very good question. What percent of people who die by suicide or make suicide attempts, if I understood correctly, abuse substances? In the U.S. general population, I don't know offhand. It's less than 50%, and it would be different based on, is it lifetime or is it past year before suicidal behavior? Depression is the one that we think about most, and there it's only about 60% of people who make suicide attempts in the U.S. population actually meet criteria for major depression. Anxiety disorder is a little bit lower, substance use disorders around the same. Minority, but it is a really strong risk factor when it's there.
Yes, can you hear me? I hope you can. So I have been working in an NGO. I've been providing counseling for the service persons, and I saw the issue that many service persons, they don't even know the difference between a psychologist and a psychiatrist and a counselor. And when whoever is coming to talk about mental health, they always have this very skeptical approach. So is there like an alternative way to approach the service person so that we would be able to establish some rapport and contact and provide care?
Yes. Also, very good question and very good point. For U.S. service members and veterans, when they're surveyed and asked, when you have a problem, a psychological problem, when you are in distress, will you go see and talk to a clinician? And about 5% of people say yes. When we ask, will you go talk to another service member or a friend or a colleague, around half of people say yes. For this reason, we've started doing work with, there's a platform in the US for service members and veterans that's sort of like Facebook, but for service members and veterans, and so they can talk to each other. We're trying to do a peer-to-peer, peer support intervention. There's a program at University of Rochester in the US that's being used with US Air Force called the Wingman program. And the focus is on trying to train other service members to be a sort of buddy to the person, and using that as a way to provide support and provide care. But you're right. Right now, a lot of the approach that has been focused on from a research, from a clinical perspective, has been the sort of medical model where we want people to go and talk to a clinician. but we see in service members, in college students, often, they don't want to go and talk to someone for fear that there's going to be negative consequences for their career, for their education. And unless we can remove that stigma, I think we need to think about other ways of getting in. So we're trying some here. If there are ones that you have in mind, I think we have to work together to figure out what's the best way to do this.
It's not a question. It is rather a tip for the previous counselor. I wanted to say that this idea about like a social network for the service persons, I think it's great. It's very effective. But at the moment in Ukraine, well, it would certainly take a lot of time to implement. And like a really instant solution, from my experience, would be that, well, you are here to help the person and you are not able to, for example, teach them some military skill, but you are there just to, for example, teach some self-help skill. You can say that, well, I'm here to teach you something useful. If it's not coming useful, then you can come back to me and tell me that, well, this was of no use at all. So in this way, you can show that you are a specialist in only your field, and they find it important if you show that you are a specialist in your field.
Okay, thank you for making that.
If I can just add a quick comment to that, there's some online work just showing the general point that if you say, we have a treatment for depression, people are not always so interested. If you say we have some coping skills we want to teach, many more people are interested, or problem solving skills. So we've started a college student focused, trying to address mental illness. It's not a mental illness group, but it's a coping skills group, or efficiency improvement, very popular with Harvard students. But it's really teaching you some sort of general cognitive behavior therapy skills. How can you sleep better, exercise, connect with other people, and so on. So really brilliant point made by the previous speaker.
Thank you so much. Thank you, colleagues. I want to talk about the impact of the hostilities on the mental health of the combatants. This has been researched all over the world, and, well, it's important because the military service persons are people who defend their country, and the leadership of the country wants to preserve the resource to keep the mental health of those who defend the country. And when we talk about mental disorders, the consequences of those, well, the outcomes could be different. Some have recovery and people get back to the service. Some get disabled, they cannot perform certain functions, or they might be deaf. And talking military language, this is the irrevocable loss. So the person cannot be returned to service and redeployed. And when we talk about mental health, suicides are, well, this irrevocable loss, as we say it in Ukraine. And there was a great study of 2019 which analyzed all the cases of suicide in the US military, in the US Army, from 1819 to 2017. I took a small screenshot from that publication, this diagram, which was published there. So blue are years without combat, yellow are years and there was some combat. And here we see the Korean War, the Vietnam War, the Gulf War, and the Afghanistan campaign. We see that suicides are not distributed evenly in time. There's the wave-like distribution, and there is link with active combat. So there is impact. War affects suicide cases distribution. When we look at the Ukrainian research, I can offer some information from the research of the National Guard service members. From 2014, the National Guard has been taking part in the combat in the east of Ukraine, and this research covers 2014 to 2019. 1983 case files have been analyzed. And the research shows that suicides have been committed by service persons who had following personality traits. Mostly it's demonstrativity, being pedantic, fixation, cyclothymia, unbalanced, and dysthymia. So, when we talk about the structure of mental health disorders, here there's a work which covers the 10 years of examining patients who were treated in the Northern Military Clinical Hospital from 2012 to 2021. So 3,995 case files were analyzed. And these are patient histories from psychiatric department. The number of service persons is commensurate with the size of the army at the time. So in 2012, in 2013, we had much less service members, and in 2014 and 15, we had an increase in the number of service members. So the number of patients also increased significantly, 6.97 times increase. We have identified 3 periods of time. The time of peace, which was used for a comparison, 2012 and 13. Active warfare period, which was April 2014 till February 2015. And then trench warfare, or it was the period of the Minsk agreements and ceasefire. So this lasted from February 2015 till 2024. We've broken it down into 2-year periods. So the first period of the trench warfare, then there was the second, and then the third period of the trench warfare. If we analyze the distribution of the cases of the diagram, we see that there are 2 types of diseases which are prevalent. First of all, these are psychogenic, neurotic disorders, coded F40 to F48, and the disorders caused by substance abuse. According to the ECD, this is F10, F19.
So, neurotic disorders dominated during the peacetime and during the trench war. Having said that, in the times of peace, psychological disorder related to substance use were on the decrease. But when the warfare began, this factor begins to increase. During the ceasefire, the substance use disorders are decreased, but it's not as low as it was during the peacetime. Neurotic disorders, on the flip side, during the active warfare are on the decrease, but increase during the trench war. In fact, they take a leading role, and they are the main disorder that the service members present with in the military hospital. Now, let us look at the structure of these disorders. Look at neurotic disorders. People mostly react to severe stress, and adaptation disorders. They account for 76.5. 77.5 are other neurotic disorders. Behavioral disorders that result from substance abuse are the key factors, and the dominant substance that was abused was alcohol. It accounted for 89.3 cases. Opioids account for 5% of all the substances abused, where people were hospitalized. Now, look at the military ranks distributions. We know that in every army, soldiers or privates make up the most of the service members. But we have divided the soldiers into two categories: professional military, those who signed the contract and they are serving and they're professional, so army members, and they receive salary. And the other group was non-professional soldiers, those who are conscripted in the peace times, who are drafted in the army, and also males who are subjected to the draft, and they have to serve for a year or 1.5 years, or who were mobilized. So they were civilians just yesterday, and they suddenly become service members and combatants. As you can see, the privates accounted for a major part of all the hospitalizations. But look at the distribution. It's interesting how these categories are distributed. Non-professional service members, for example, who were mobilized, they dominated during the peaceful times and active warfare. When it comes to professional service members, they become hospitalized more intensively during the ceasefire periods. What does that mean? First, the army is getting ever more professional. Therefore, the majority of hospitalized are professional military these days. Non-professional military people were mobilized in 6 waves during the active warfare, and they made up a large share of the armed forces. And you can see it in the graph, because you can see there a large share of non-professional service members who were hospitalized during the active warfare. The third category are the the NCOs, non-commissioned officers. They are somewhere in between the professionals and not professionals, and these officers have somewhat different distributions. They're not the same as professional service members, because during the active warfare, there were 24% of the NCOs who were hospitalized. It's quite a high rate. Now look at the condition distribution diagram. The frequency of the disorders and which category of service members. So the highest frequency is demonstrated by non-professional soldiers who were mobilized. The diagram says that these soldiers are oftentimes presenting with psychiatric disorders due to substance use. Professional military, they are indicated here in black, the color. It means that they suffer from psychogenic disorders. When it comes to NCOs, you can see that the distribution is 50-50 for this category. But we also looked at the officers, including senior officers at captains, major, lieutenant colonel, and colonels, and black color dominates, the higher you go up the military rank, which means that the higher the rank, the higher the probability to have a psychogenic disorder. The length of stay in the hospital for service members. It's quite logical that we take the disorders that have the highest frequency, such as psychogenic and substance use disorders, and we look at the length of treatment of this patient. During the peaceful times, it would take up to 30-40 days to treat them. During the active warfare, this is shortened up to 10 days. What are the causes? For example, there's a sharp increase in the number of the service members treated. Moreover, we can also think that during the active warfare, there were many disorders, but they were mild disorders. So patients improved in 7 to 10 days. Another phenomenon we can notice is as follows. We can look at substance abuse disorders. 10 days of hospitalization during the active warfare, which means that a lot of the service members were hospitalized during because they were intoxicated, not because they were systematically abusing certain substances. Okay, hospitalization length of stay depending on the military rank. You can see that the data mirrors the structure of the disorders. During the peaceful time, non-professional service members are staying the longest, but during the trench war, it's the professional service members who spend the longest in the hospital. So, therefore, professional service members had more severe disorders. So, what are the outcomes? The importance of psychological skills to improve adaptation in professional service members and the officers. Second, non-professional service members tend to abuse alcohol. So mobilization makes people more prone to drinking. Therefore, people who are prone to alcohol and substance abuse should not be in the army, and greater effort needs to be made to screen the army for them. And third is that active warfare multiply hospitalizations. So what is to be done? Transferring treatment to other facilities and sequencing the treatments. So the service members need to be referred to hospitalization or rehabilitations to other hospitals or facilities that were in a safer place, somewhere further from the front line. Thank you for listening.
It was really brilliant talk. Congratulations on really important work. One question that I have is something that we've been struggling with on our end, and that is thinking about screening and who to screen in and who to screen out, and what advice to give to the military about trying to get accurate reports. To the earlier speaker's comment about relying on people's self-report, you mentioned that at a few points, screening out people who are prone to risk of alcohol overuse. And I'm wondering about how much that's possible for people, to get accurate reports from people. And I don't know as much about service in Ukraine, about are there ways of intervening while people are in the military to decrease risk of alcohol misuse. I'm just wondering about how you are thinking about that.
Okay.
Well, first, it's about the work of the so-called military medical commissions. They check the health of the recruited servicemen, those who are beginning their service in the armed forces. And what we do is first we look at the patient history. So the person needs to report the certificates from the psychiatrist and the substance abuse doctors that these persons have never been treated for substance use before. And the second thing is psychological tests. Audit, for example, is quite an effective tool to screen out the poor candidates. And we also do the so-called biological tests, i.e. blood tests, so we can see probable risks if the person is drinking alcohol presently or not drinking. It's a very specific method that we use to screen people more meticulously.
Thank you so much. I can ask. Yes, I'm so grateful for you that you give this. And I have two short questions. First, they spend a lot of time in the front line. And soldier who came back and they was injured, they lost, for example, their hand or their legs. Then a soldier who came back but without any problem with the health.
Is the risk of suicide ideations and suicide is higher in those who has serious physical problems due to combat? For example, when they lost their...
For example, if some family, they lost somebody in the war. For example, some woman, she lost a husband. Or mother, she lost a son. It can have a risk to commit suicide because of this news.
Yeah, I'm curious if Andriy has a response as well. They're complex questions in that, medical disorders overall are associated with higher risk and some more than others. Pain-related disorders, for instance, convey much higher risk of suicide than non-pain-related disorders. And I think that's in part because we think about suicide as a way of escape from seemingly intolerable circumstances. And so it would make sense that if there's pain involved, the person would want to escape. Terminal illnesses as well, cancer and so on. I don't know about a combat-related injury, whether that would increase risk more than somebody without such an injury. So your question is, I think, too nuanced for where the research is at. Loss as well, it gets tricky. In our world mental health data, looking across many different countries, husbands losing a wife have increased risk of suicide. Wives losing a husband do not. So I think there's going to be moderating factors in terms of who has the loss and what's the nature of the loss and so on.
A related question, if I may, then Matthew,
do you see...
sorry.
A follow-up comment on that question.
Yeah, go ahead, Andriy.
Actually, it's a big, interesting question because the person who's has a physical injury or has a physical deformation seeks more attention and gets more attention from the social services and from the healthcare professional. And if a person does not have any visible sign of an injury, then these people get less attention usually. So you need to remember that. Thank you, Andriy.
Okay, if I may chime on that topic about physical injuries.
Хочу додати.
Is it okay? Yeah. Just a follow-up briefly. We have had a webinar on sexual abuse cases, and do you feel that, Matthew, that in the research that in sexual abuse in war, there's also a higher tendency for suicidality or suicide? We've seen it actually in the Bosnian War, before the genocide. But I wonder if that, we've heard cases here being reported in Bakhmut and other places, but is it also something that the literature has showed?
Yes, childhood and adulthood sexual abuse and physical abuse are some of the most consistent across groups, across age periods, the most consistent risk factors for suicide. And when we look at a range of different potential traumatic events that a person might experience, from natural weather events to physical assault, to childhood maltreatment, physical and sexual abuse consistently come out as very strong risk factors. So.
Доброго вечора. В першу чергу хочу привітати.
Good evening. First of all, I would like to say hi to Mr. Andriy, because we've been knowing each other for over 20 years. I'm so happy to saw him presenting here. But I might ask a trick question. War and psychoactive substances are always hand-to-hand, and we've seen this diagram on the distribution of different substances, and alcohol is the most widespread. But if we go narrowly, why are we only considering the psychoactive substances from the negative angle? What if, at least let's talk about alcohol, what if it actually helps in coping? If it's an adaptation agent? Because how can we expect normal response from normal people in really unnormal circumstances? Yes, they are normal people, but at war, they see atrocities daily. And if we take the alcohol away from them, what if it increases these psychogenic reactive conditions? What if we make worse than what we have now? So it's a trick question. I'm sorry for that. Thank you.
Got it. Yeah.
Дякую, Вячеслав. Я також тебе дуже радий бачити.
Thank you.
Все в порядку.
Thank you, Vyacheslav. I'm also happy to see you. And indeed, alcohol also might have some adaptation features. It's still researched. It's a matter of discussion. So yes, there are researchers that look at it differently. But the idea of our study was to show the structure of disorders. So we are not saying that things are only bad or only good. In terms of alcohol abuse or other psychoactive substance abuse, the here we might have to see if it's simple use or acute intoxication or real addiction, a long-term addiction. And the format of our study did not let us differentiate. Maybe subsequently we will look into it deeper and break it down. But in my opinion, people who have addiction as such, well, they probably should not be engaged in active service, because they well, might actually be quite harmful to the general cause. Good evening. I rather wanted to share a small experience. I have once worked as deputy head of psychology service in the National Guard, and I was engaged in the study which Andriy mentioned when we studied the suicidal tendencies among the service persons. In 2019, there was a guidance published, and there we incorporated world's best experience in suicide prevention. We had it introduced for the National Guard, and we've incorporated the standards and principles of preventing suicidal behaviors in armies of the NATO countries. In particular, we've introduced the suicidal risk checklist, the questionnaires for suicidal behaviors, and one of the main ideas there was awareness campaigns among the service persons about suicidal signs and symptoms. And this awareness campaign, actually in the first year after its introduction, has given quite a positive result. We had almost 2.5 times less attempts and deaths by suicide. And if I remember correctly, over 30 to 40 people reported to the hotline within the year, and we managed to provide fast response when service persons observed their comrades with symptoms of suicidal behaviors. Then the psychologists could intervene within minutes or like dozens of minutes, and they would prevent the actual suicide. So besides peer-to-peer approach, awareness campaigns, they are really great at preventing suicides, because screenings only and testing and questionnaires, yeah, sometimes the service persons are coached, but when they understand why that is necessary, when there is this awareness campaign and people understand why it matters, they can help look at the other's behavior. Thank you.
Thank you for this positive example, actually. And I think this is really important to know that best practices are being implemented and they have a positive outcome. If I may, I would share one of the, I think this is a great value of those talks as well, that this knowledge could be delivered to international community. The comment I have heard yesterday from colleagues who support Ukrainians and Ukrainian army and mental health issues in Ukrainian army give me a comment that they rarely hear a feedback that something that expertise they provide actually what's happening next. Is it implemented? Is there any outcome? Is it positive? Is it or not? So I think this conversation is really important, and we know the sensitivity of the issue and confidentiality, and Andriy is sharing data that was the research was done like during the last decade, so we can talk now about the numbers. We cannot talk about the numbers openly now, but yeah, we can at least build this dialogue between experts. And if I may, I would like to say a special thanks to Matthew, of course to Andriy, but as you may know, or you might probably not, Matthew, me and my colleagues, we have launched a chatbot called Friend, Druh, on the second day the war has started. We have so far 100,000 users activated this chatbot. And I have recently analyzed the feedback, and one of the feedbacks that people evaluated what was bad about the chatbot, that we don't have any recommendation intervention about suicide. So meaning that if I have suicidal thoughts, you do not provide me with any suggestion or recommendation. And then my fear was, when I saw this, I thought, okay, so we should do something. What we can do, probably we should provide the hotlines, you know, the numbers where people can talk about it. And in the conversation with colleagues who work with digital interventions on suicide, they actually said that it's better to give at least some advice, recommendation, or some conversation with the person. Because probably if people, in Ukraine especially, have a high level of stigma, they might even not considering calling those hotlines. So giving some psychoeducation with chatbot, you know, it's not the personal communication, just might be helpful. So really great to see your work, and yeah, we can borrow some.
Thank you. Very, very cool to hear, and please let me know if I can be of help in any way. I think this is a very, very important direction for all of the reasons that you said, you know, stigma, access, and so on. In the US, there's been a little bit of a cold response, and people say, well, that's an imperfect intervention. Sure, it's not perfect, but it's, as you're saying, something is often, not always, but often better than nothing. And this can help decrease stigma, make connections, increase people's likelihood of getting care. And we have to test and see what works and what doesn't, make sure we're not harming, and get better at helping.
Exactly. Yeah.
Probably we need to stop.
Yeah, so let's almost close the session. Before doing so, let's make it a tradition that before we close, that you open your camera and you just wave to all the audience. But in doing so, I would like to thank Matthew Knox for a brilliant presentation, and Andriy also for a brilliant follow-up. This is important. We're in it, and this problem will not go away quickly, but we'll like to educate you. We'll keep doing that. And this is beautiful. Just wave your hands and we'll see you in 4 weeks again. Same time, same moment. Brilliant. Wonderful. Yes. Thank you. Looking forward.
Next.
Hang in there. And great that I'm here sharing this with Irina together in the same Zoom session.
Okay.
All right.
Bye.
Bye-bye.